I'm going to add to FFR now. And it's always, we wonder why we do so many less FFRs when compared to so many PCI in our country or world over. So this is a question which we ponder over all the time. And then one of the reason is, is because FFR is a little cumbersome to do, maybe expensive. We'll see all of that. So what are the other ways we can assess coronary stenosis other than FFR? And then comes the non-hyperemic indices. If you see the non-hyperemic indices, which we have here, sorry, I don't have a pointer. You have the whole cycle methods like resting, FFR without hyperemia, RFR, IFR, DFR, DPR. These are the common non-hyperemic indices which we use. If you look at that, I usually use FFR or RFR. Most of us would be using these two modalities which we are familiar with. Let us look into those modalities in detail. So world over, the FFR adoption rate is less. It is because of many reasons. Adenosine, we need to give adenosine, side effects of adenosine. It increases the procedure duration time. It may be expensive. IV adenosine is expensive. So these are all reasons why we don't do as much FFR as we want. So, and in addition to that, if we don't give sufficient hyperemia, your FFR is going to overestimate the lesion. So basically you will get false high FFR if you don't create sufficient hyperemia. So this is always a concern, and whenever we give adenosine, we look for if the patient has bradycardia or not. There is no good clinical way to see if patient had good adenosine effect or not. So this again, it causes a sense of doubt in us whether really was adenosine, did we really achieve hyperemia or not. So we stop trusting our FFR values at some point. So, and now, the previous speaker spoke about IV versus intracoronary adenosine. There are recent studies which said that both are equivalent. But there's so many disadvantages of using intracoronary adenosine, mainly because you can't use them in ostial lesions, you can't do a pullback with intracoronary adenosine. There's a chance that, you might inject some bubbles. The effect lasts only for 35 to 40 seconds after intracoronary adenosine. So, you can't use the side hole catheters, so many other reasons where you can't use intracoronary adenosine. So, if there is a chance, IV adenosine is better than intracoronary adenosine. So, and what is other problem with FFR? I think, when we do a regular FFRs, you see that, many times you get different values of FFR. And this happens even when you do IV adenosine also. So, and then we take the lowest value of FFR. So this is again one more problem with FFR. So to overcome all of this, so we came up with some other modalities which we thought would be better than FFR. Still they have not become gold standard. So those methods are these, where we measure all the modalities measure only one thing: pressure beyond the stenosis, pressure proximal to the stenosis, that is aortic pressure. All the modalities measure the same thing. They measure at different parts of the cardiac cycle. So if you see the first three modalities, FFR, resting PDPA and RFR, they are whole cycle measurements. And if you see IFR, DFR and DPR, so they measure at part of the diastole. So if you look at, this is the cardiac cycle, you will see there. If you look at this cardiac cycle, so the IFR, it measures the PD by PA only in this part of the diastole, right? So why do these measures, they measure in particular part of the diastole? Because in the later part of diastole, the microvascular resistance is constant. So that gives us a window to measure PDPA, which are reliable and which are reproducible. So that's how they came up with these measures, where you don't need hyperemia to get reliable, reproducible PD by PA. So, but then if you want to do these measurements, what do you need? You need a stable cardiac rhythm, because you want a good cardiac cycle which is reproducible. Every QRS should be similar, so you need a stable cardiac rhythm, a good quality ECG. Patient should not be breathing a lot, good respirations, and there should not be any hyperemia. If you have done FFR and you want to do IFR after FFR, you need to wait for 40 seconds to 1 minute until the hyperemia subsides. So these are all prerequisites for doing a good IFR or RFR. So are they all same? If you look at the cutoff values, most of the non-hyperemic indices have a cutoff value of less than 0.89. So clinically, we use IFR and RFR commonly, but most of them, they're similar, for clinical use at least. So what is IFR? So we saw how IFR was measured. So how is IFR different from FFR? So IFR, you measure the PD by PA in the late part of diastole. So then why is FFR less than 0.80 significant, but for IFR we take it as less than 0.89? Why? Because in the resting state, your microvascular resistance is little higher when you are measuring IFR. For FFR, you create good hyperemia, so your vascular resistance is lower. So that's why your IFR values are a little higher when compared to FFR. So, and IFR, RFR are almost 80% as accurate as FFR. So the same thing with RFR. The RFR, the way it's measured is different. It takes the whole cycle, but it's going to take the lowest value in the cycle. So it literally measures the same thing. So then what are the weak points of IFR or RFR? They hold good for both IFR and RFR. So you need a good ECG, and these are all done by proprietary systems. You know, IFR is by Abbott, and RFR is by Abbott, and IFR is by Philips Volcano. So they have their own proprietary system built into measuring these things, these values. So coming to what are the fallacies in measuring these? If you look at this, when you have serial stenosis in an artery and you're measuring IFR, when you're measuring FFR, for example, one stenosis will influence the other. So when you're doing FFR, okay, so you basically, one stenosis, the effects of the hyperemia will influence more. This influence is less with all these non-hyperemic indices. And the pressure drift, what you see, I think the previous speaker spoke about the pressure drift. So because the resting difference between PD and PA is less in IFR and RFR, so they are more sensitive to pressure drift. So you have to always make sure that you pull back the catheter, there is no significant drift for IFR, RFR. But it is less forgiving for FFR. And if patient has tachycardia, again FFR is better when compared to IFR, RFR, because you need a good diastolic period here for measuring IFR. So this was a patient, one of ours, where you can see patient is doing recurrent ectopics. When we are doing IFRs, you keep getting little different values. Even though it was significant, you get different values when somebody has unstable rhythms. So coming to the different coronary artery territories for IFR and RFR, if you look at the RCA, the perfusion of RCA is predominantly in systole, right? Unlike the left has significant perfusion in diastole, RCA perfuses both in systole and diastole. So if somebody has perfusion in diastole, these are the measures which are done in diastole. So they have less sensitivity for measuring RCA lesions when compared to the left system. And serial lesions, the thing which I mentioned, if one stenosis is interacting with the other stenosis, so you have crosstalk between the stenosis, your FFR becomes little less unreliable because the interaction between the stenosis is exaggerated by adenosine. So you need something, a stable state, to measure the significance of each stenosis. So in this, when you are evaluating tandem lesions or serial stenosis, again, IFR or RFR are better than FFR. So see this, when we are evaluating this kind of lesions, where you have multiple lesions in the LAD, proximal LAD, mid LAD, distal LAD, and you want to assess the significance of each lesion, in this scenario, still IFR, RFR are much better than FFR. And this was another patient where you can see when we are doing RFR pullback, when you are doing RFR, you can see you can map the significant stenosis where it is in the artery. So coming to the left main and proximal LAD, this is again, we have less data whether FFR is better or IFR, RFR are better. So the most of these patients are excluded from trials, so we don't know. So IFR, RFR are not validated in this subset, but if you go logically, so many patients with left main stenosis, they tend to have downstream stenosis, either in LAD or LCX. So if you go by that logic, the IFR and RFR should perform better than FFR. Acute coronary syndromes, again, we don't have data, but we all know that immediately after acute coronary syndrome, there is some disturbance in the microcirculatory resistance. So again, something like IFR, RFR should theoretically be better when compared to FFR. So aortic stenosis, again, we used to do a lot of these patients when they come before TAVR, before SAVR, we do angiogram, we find intermediate lesion in the LAD, and then we just do a IFR or RFR on the table immediately, and then we used to send them for TAVR or SAVR. We used to do loads of them. Most of us are worried about giving adenosine, IV adenosine or intercoronary adenosine in patients with aortic stenosis. So we want something which is we feel is safer. So we prefer IFR RFR. Is IFR RFR better than FFR in this subset? Yes. Why? Because in aortic stenosis, your resting microcirculatory resistance is lower. So the effect of adenosine is less in patients with aortic stenosis. So your RFR IFR is way better than FFR in this subset. So if you summarize all of them in different conditions, you can see that in tandem lesions, diffuse lesions, LAD, left main with downstream stenosis, acute coronary syndromes, all these things, IFR, FFR looks much better. It fares better when compared to FFR. So, but left main, where, but because of the validation of trials, in left main, patients with systolic dysfunction, when you're rushing side branches in bifurcation PCI, all these subsets, it's better done with FFR. So, let me, sorry, couple of more slides. But coming to the current clinical evidence in the guideline status, IFR is better than FFR. IFR has class 1A evidence, and it is the preferred non-hyperemic pressure index which we can use. But RFR can be used interchangeably with IFR. Thank you. I think this is my summary slide. Yeah.